Welcome to section 11 of metabolism. In this section, we'll be discussing fat metabolism. Let's get started. This is the metabolic map provided in section 1 of metabolism. In this video, we're focusing on fatty acid metabolism, both the synthesis of and breakdown of fatty acids. The fatty acid metabolic pathways can be seen right here. Let's zoom up on the pathway. This is a detailed figure of fatty acid metabolism, which can be found in section 11 of metabolism. Notice that both fatty acid synthesis and the breakdown of fatty acids are shown in this figure. Fatty acid synthesis is shown on the left right here, and fatty acid breakdown is shown on the right here. As usual, enzymes are shown in red and important notes are denoted at the bottom right side of the image. Let's discuss fatty acid synthesis first. You should know that fatty acid synthesis primarily occurs in the liver and mammary glands, and that fat is primarily stored in adipocytes. As we go through the pathway, we'll assume that the synthesis is occurring within the liver. If you think about the synthesis of fat, it should make intuitive sense to you that this should be occurring during high energy states. So high energy. This seems logical, right? You wouldn't want your body to be using energy to synthesize fats if you were starving. Recall from the video on the TCA cycle that citrate, which you can see right here, is formed from acetyl-CoA and oxaloacetate. Also recall that citrate levels rise during high energy states because the ATP and NADH, which we can see right here, that are produced from the electron transport chain and the TCA cycle, inhibit isocitrate dehydrogenase. This causes citrate to be funneled across the mitochondrial membrane into the cytosol and converted into acetyl-CoA and then malonyl-CoA. So you can see it funneled across the mitochondrial membranes, then converted to acetyl-CoA and then malonyl-CoA. Notice that citrate upregulates acetyl-CoA carboxylase. You can see that right here. And thus citrate promotes fatty acid synthesis. Also notice from the figure that biotin, which you can see right here, is an important cofactor for acetyl-CoA carboxylase. Therefore, fatty acid synthesis may be impaired in patients who are biotin deficient. Also notice from the right side of the image that malonyl-CoA right here inhibits carnitine acyltransferase 1 or CAT1. This should also make intuitive sense to you. You wouldn't want to be simultaneously synthesizing and breaking down fat, and malonyl-CoA is the molecule that provides this regulation. From here, notice that NADPH produced from the HMP shunt is required to convert malonyl-CoA to fatty acids. And notice that this occurs by the enzyme fatty acid synthase. Glycerol can then be combined with a fatty acid to form triglyceride. So it's not shown in the image here, but if we drew it in, glycerol would be combined with a fatty acid to form triglyceride. Okay, now let's discuss fatty acid catabolism. The first step involves the mobilization of stored triglycerides within adipocytes. You should know that triglycerides are heavily stored in adipocytes, and these are broken down by the enzyme hormone-sensitive lipase, which you can see right here. The glycerol is transported to the liver to be used for gluconeogenesis. The fatty acids travel throughout the body to be used in various tissues by the TCA cycle, which results in the production of energy. It's important to know that the brain cannot metabolize fatty acids and instead must rely exclusively on glucose and ketones for energy. Notice that glucagon, catecholamines, and ACTH, which you can see right here, all upregulate hormone-sensitive lipase. And also notice that insulin downregulates hormone-sensitive lipase. Hopefully this is intuitive for you and you don't have to memorize this information. Glucagon, catecholamines, and ACTH are all increased during a fight or flight response. The body responds to this by increasing fat metabolism to provide energy for the body during the stress response. Glucagon is also increased when the body is fasting and thus promotes the breakdown of fat to provide energy for the body. Insulin is a marker of high energy, so it should make sense that this would inhibit fat catabolism. Okay, for the remainder of the pathway, let's assume a fatty acid is being metabolized within the liver, but recognize that this occurs in multiple tissues. If we continue following a fatty acid, we can see that it's converted into acyl-CoA and then acylcarnitine. Notice that this step is catalyzed by carnitine acyltransferase 1, or CAT1. As we've already discussed, this enzyme is inhibited by malonyl-CoA. The acylcarnitine can then be shuttled across the mitochondrial membranes into the matrix, where acylcarnitine is broken down into carnitine and acyl-CoA. This carnitine shuttle is important because the mitochondrial matrix is highly negatively charged and is otherwise impermeable to large fatty acids. Thus, the carnitine shuttle allows fat to enter the mitochondrial matrix. So remember, the carnitine shuttle allows fat to enter the mitochondrial matrix. It's important to know that carnitine is primarily involved in shuttling long-chain fatty acids into the mitochondrial matrix. Once acyl-CoA is in the mitochondrial matrix, it can be broken down by a series of steps that results in the production of acetyl-CoA. This portion of fatty acid breakdown is also referred to as beta oxidation. Notice that this is catalyzed by the enzyme acyl-CoA dehydrogenase. Also notice that this results in the production of FADH2 and NADH. Recall from the video on gluconeogenesis that acetyl-CoA cannot be used in gluconeogenesis in the liver because it does not provide additional carbons to the TCA cycle. So once acetyl-CoA is produced, it is either used in the TCA cycle or converted into ketones. You can see that right here, the TCA cycle or ketones. During times of excessive fatty acid breakdown in the liver, the TCA cycle becomes inhibited and all excess acetyl-CoA is used to produce ketones. Ketones are discussed in a separate video. Okay, let's do a question. A 26-year-old female presents with a 2-month history of constipation, depression, and kidney stones. She has also noticed white discharge from both nipples during this time and thinks she may be lactating even though she has no children. Over the past several days, she has experienced several episodes of syncope. She states that several of her family members have been diagnosed with calcium problems. An initial blood glucose measurement reveals hypoglycemia. How will the activity of carnitine acyltransferase 1 likely be altered in this patient? From the question stem, hopefully you notice that this patient has multiple endocrine neoplasia type 1, or MEN1. Recall from pathology that MEN1 is characterized by the 3 Ps. These stand for pituitary tumors, pancreatic tumors, and parathyroid adenomas. This patient has hypercalcemia due to a parathyroid adenoma. This has resulted in constipation, depression, and kidney stones. You can remember the symptoms of hypercalcemia with the mnemonic stones, bones, groans, and psychiatric overtones. We also know that she has a prolactinoma because she is experiencing white discharge from both nipples. Finally, we can deduce that she has an insulinoma because she's had several episodes of syncope, which was likely due to hypoglycemia. Okay, so this question is essentially asking how high levels of insulin will alter the activity of CAT1. Let's pull up the figure for fatty acid metabolism to answer this question. From the figure, notice that insulin is seen right here and right here in our figure. So it increases the activity of acetyl-CoA carboxylase, and it decreases the activity of hormone-sensitive lipase. Upregulation of acetyl-CoA carboxylase would result in increased levels of malonyl-CoA. From the right side of the image, we can see that malonyl-CoA right here inhibits CAT1. So our patient with an insulinoma would likely have decreased activity of CAT1. Okay, let's continue discussing the pathway. From the figure, you can see that there are 2 disorders in the key associated with fatty acid catabolism. You can see them right here. As you can see, there's a green star next to carnitine right here. This represents a disorder called systemic primary carnitine deficiency. This is actually not caused by a defect in carnitine itself. Rather, it's a result of a defective transporter protein that allows carnitine to be shuttled into the mitochondrial matrix. Carnitine is normally reabsorbed by the kidneys, but a similar transport protein that allows carnitine to enter the mitochondrial matrix is also defective in the kidneys. This means the carnitine is lost in the urine, resulting in low levels of carnitine. So decreased carnitine reabsorption by the kidneys results in decreased carnitine. Because carnitine is low, acylcarnitine will not be formed either, resulting in low levels of acylcarnitine. If acylcarnitine is unable to enter the mitochondrial matrix, then beta oxidation is impaired, resulting in low levels of acetyl-CoA. Because acetyl-CoA levels decrease from impaired beta oxidation, the enzyme pyruvate carboxylase is downregulated. Let's look at a figure from pyruvate metabolism so you can see what I'm talking about. Recall that acetyl-CoA normally upregulates pyruvate carboxylase, and this promotes the conversion of pyruvate to oxaloacetate, and this is the first step in gluconeogenesis. Because acetyl-CoA levels are low, pyruvate carboxylase is downregulated. Therefore, gluconeogenesis is also downregulated, which results in hypoglycemia. Because ketones cannot be formed, the patient will also be hypoketotic. This results in the unique presentation of hypoketotic hypoglycemia. So hypoketotic hypoglycemia. Because long-chain fatty acids require the carnitine shuttle to enter the mitochondrial matrix, these will accumulate within the liver, resulting in liver dysfunction, hyperammonemia, and encephalopathy. So increased long-chain fatty acids results in liver dysfunction. Okay, let's see what your text says. So again, systemic primary carnitine deficiency is caused by a defective carnitine transporter protein. This results in the loss of carnitine in the urine, so carnitine levels will be low. This impairs beta oxidation, resulting in decreased ketones. Because acetyl-CoA levels decrease from impaired beta oxidation, the enzyme pyruvate carboxylase is downregulated. This results in decreased gluconeogenesis and therefore hypoglycemia. Because long-chain fatty acids require the carnitine shuttle to enter the mitochondrial matrix, these will accumulate within the liver, so increased long-chain fatty acids. This results in liver damage and hyperammonemia, resulting in encephalopathy. Because the symptoms are a result of low levels of carnitine, supplementation with carnitine can improve the symptoms. Okay, let's move on. From the figure, notice that a defect in acyl-CoA dehydrogenase, which you can see right here, also results in a disorder of fatty acid metabolism. At the bottom of the screen, you can see medium acyl-CoA dehydrogenase deficiency, or MCAD deficiency. In reality, there are multiple variants of acyl-CoA dehydrogenase enzymes that each are responsible for metabolizing different lengths of fatty acid chains. A medium chain fatty acid is considered 6 to 10 carbons in length and is metabolized by MCAD. There is a long chain acyl-CoA dehydrogenase, a short chain acyl-CoA dehydrogenase, and so forth. However, all of these variants present similarly to MCAD deficiency. Because MCAD deficiency is the most commonly tested, we'll focus on this particular disorder. From the figure, we can see that an MCAD deficiency would result in impaired beta oxidation. We should be able to conclude then that MCAD deficiency and primary systemic carnitine deficiency will present similarly. Let's look at your text to distinguish the two. MCAD deficiency is a result of a defective acyl-CoA dehydrogenase enzyme, but similar to systemic primary carnitine deficiency, results in impaired beta oxidation. This means patients with MCAD deficiency will have hypoketotic hypoglycemia, liver dysfunction, and encephalopathy. However, the two disorders can be distinguished by checking the levels of carnitine or acylcarnitine. Remember, in systemic primary carnitine deficiency, carnitine and acylcarnitine levels are low. In MCAD deficiency, the carnitine and acylcarnitine levels will be normal. Most often, if you are ever required to distinguish the two on a test, you'll be given a clue about this particular point. For example, the question stem may say something about elevated levels of acylcarnitine in the blood or high levels of carnitine present in a tissue biopsy. Also note that in MCAD deficiency, long-chain fatty acid levels will be normal. This is because these can be metabolized, whereas in primary systemic carnitine deficiency, these will be elevated because they cannot enter the mitochondrial matrix. However, this is not always a good way to distinguish the two disorders because the patient could have a long-chain acyl-CoA dehydrogenase deficiency, which would also result in elevated long-chain fatty acids. Therefore, the best way to distinguish the disorders is by examining carnitine and acylcarnitine levels. Okay, let's do a question. A previously healthy 10-year-old Jewish boy is brought to the ED by his mother, who states that he developed nausea and vomiting, followed by a syncopal episode after participating in a fast for Yom Kippur. Labs are significant for hypoglycemia and non-detectable levels of acetoacetate. A muscle biopsy reveals normal levels of a protein responsible for transporting long-chain fatty acids into the mitochondrial matrix. It is determined that impairment of gluconeogenesis likely resulted in hypoglycemia. Decreased activity of what enzyme involved in gluconeogenesis most likely explains these findings. From the question stem, we should be able to gather that this patient has MCAD deficiency. We can deduce this because he developed hypoketotic hypoglycemia during a fast. You should know that acetoacetate is a keto acid, and this boy has non-detectable levels of acetoacetate. We're also told that the problem is not due to a carnitine deficiency based on this part of the question stem. So a muscle biopsy reveals normal levels of a protein responsible for transporting long-chain fatty acids into the mitochondrial matrix. So again, this part of the question stem is referring to carnitine. Okay, so we're told that gluconeogenesis is impaired and asked what enzyme is likely responsible. Let's look at the overview figure to answer this question. From the figure, we can see that an MCAD deficiency would result in decreased levels of acetyl-CoA. In the figure from pyruvate metabolism, we can see that acetyl-CoA normally upregulates pyruvate carboxylase, which promotes the conversion of pyruvate to oxaloacetate, which is the first step in gluconeogenesis. Because acetyl-CoA levels are low, pyruvate carboxylase is downregulated, and therefore gluconeogenesis is also downregulated, which results in hypoglycemia. So in answer to our question, gluconeogenesis is likely impaired due to decreased activity of pyruvate carboxylase.